So good morning, everybody. Today we are taking a basic means walkthrough about the pacemaker and its functioning. How we code the pacemaker, how we put the mode options. So those things we will be discussing. Let me go to the presentation. Okay. So basic concept in the pacemaker. So there are two things: code and mode. So first about there is a NASPAC, or this means North American and British pacemaker. What you call coding means there is a body is there in which they have put some particular method of naming any pacemaker and their codes. So there are three. We can say there are four important parameters which you may be seeing all the time. So if you can see, there is the first is the chamber pace, chamber sensed, response to the sensing, programmability means rate modulation we can do, and anti-tachycardia function. So when we are using the pacemaker mode, we are saying that the first chamber in which we have put like we are saying VVI. So V is the pacemaker chamber in which we are pacing. V is the same only single chamber where we are sensing, and I means inhibiting. So there are function only one. So if you are going to see single chamber pacemaker, there is a single pacing, single sensing, and single response. And when we are going for DDD, dual chamber means atrial and ventricle pacing, atrial and ventricle sensing, and again D, triple D. D means dual response. One is inhibited, second is triggered. When the sensing is happening, what next? Sensing means when we are putting a wire inside the heart, what exactly it is going to do when it sense means some signals is being sensed on the lead, what it should do. It should become silent or it should start pacing. When it is start pacing, we call as triggered or tracking. Sorry, mostly triggered words say. And if it signals is coming, it say you should not pace. So these are two functions of pacemaker. Either it get inhibited or it get activated. So when activated it is called triggered, and when it is inhibited it is called when it is inhibited means it is sensing mode. Okay. So now coming to the case. So what are the common pacemaker mode which we are selecting? So for the sinus nodal diseases, the AI pacemaker, because the disease is at atrium level and at the sinus level. So what best pacemaker you can implant? It is AAI. But you have never seen that AI pacemaker has been written anywhere. It's all the time dual chamber. The reason is when the AV node is diseased, most of the time, over the time, means when the person is been diseased, it is possible that the same atrioventricular disease will be happening. Means SA and AV node are sometimes affected, or over the time, maybe at 60, 65, 6NS has developed. Later on, AV conduction disorder has also started. So you are not going to put a new lead. So that's why the common mode is dual chamber pacemaker people implant, or we can think the sinus node is associated with the AV conduction disorder. That's why nobody want to take a chance to put only one lead and let on AV conduction disorder happen. So these are the common pacemaker which we are able. Six sinus node, it is AI. R means rate responsive, means when the person start walking, heart rate should go up. When the person is sitting, the heart rate should come down. So it should behave like a physiological changes. For the AV block, if the patient is having only AV block, the preferred mode, or you can say preferred option is VDD. Ventricle should pace, and D is the you are having one sensing in the atrium. So this is a chamber which is paced, and D means chamber which is sensed. So both the chambers has been sensed, atrium and ventricle. D means both the response is there. If atrium is pacing, so atrium is sensing and ventricle is not sensing, it will track. So like that, that's why D is response inhibited as well, and R means rate responsive. The time.
Even though there is no electrode in the atrium, it will sense.
No. We are pacing only ventricle. We can't pace atrium, but we are having lead. Sensing is D. Na? So D ventricle pacing is only one chamber. You can pace only one chamber, but you can sense two chambers. So that is D. So you must have either two leads or a one lead with one sensing electrode in the atrium. So there are companies. Previously, this was the one of the common mode when the complete head blockage. One lead we are putting in the atrium, one in the ventricle. This can't pace it. Only this can pace. So when the AV block is there, it will sense and it will track. Sense, track, sense, track. You are getting this point? Tracking means यहाँ पर जो response है, after 120 seconds, what is the PR interval? It will start giving this pacing like that. So AV synchrony will be maintained. That is the reason. 6 sinus plus AV conduction disorder, if it is there, it is a DDDR made. Wherever the 6 sinus, R should come. Rate response. Okay. So say sinus nodal disease, AV conduction, so it is a dual chamber. We don't want AI, we want dual chamber. Chronic AF, this is the only one condition. Chronic AF means the patient is having totally ongoing AF. The mode is VVIR or VVI, whatever you want to say. So in that, and there is one condition we call the carotid sinus, sensitive carotid sinus syndrome. So patient's carotid, whenever you are pressing or he is turning on that side, it get compressed and it is super sensitive. So all of a sudden the heart rate goes to complete heart block. So in that scenario also, the dual chamber pacemaker with hysteresis, there is one function in the pacemaker which has been kept. And alternative, the patient don't want, if the patient don't want a response, then AI, DDD, DDD, VVI, mean, these are the, but the best mode, if means question is asked, what is the best mode for pacemaker for 6 sinus syndrome? It is AAIR. For dual chamber, it is VDD. For the 6 sinus with AV, it is DDR. And if the patient is having chronic AF, at least for chronic AF, you should know if the patient is having ongoing AF or you have written the patient diagnosis of permanent AF, the pacing mode is not dual chamber, it is a single chamber. Why? Common sense. Atrium is already diseased, na? Already it is fibrillating. What you are going to do? Pace there. So there is no need of pacing there. Okay. Chronic AF. If it is an intermittent AF, it is a paroxysmal AF, then you have to go with the dual chamber pacemaker. Okay. So this is the choices what we make. So when the diagnosis, so diagnosis of bradycardia, atrial fibrillation is there, rate response versus non. So rate response is needed or not. If it is rate response is needed, then it will go to this one. So single chamber pacemaker, you can see this is single chamber upper chamber. It is automatically going on. Yeah. So this is very easy to implant. Put one lead and come out. Yeah. So this part I already have discussed with you. So single chamber, you will be getting how to identify the patient is having single chamber versus dual chamber when the pacing spikes are there. So if you can see here, spikes are coming and the PR, you can see the PR is never fixed. It will change because if the patient is having, yes, single chamber. So this PR will be changing. When it is a dual chamber pacemaker, the PR will be fixed. T and for that interval is always fixed. Okay, so in that, because here the lead is in the ventricle and it is not associated with any activity what is happening in the atrium. So if a complete heart block patient is there, P is happening and you have just put a one lead, so ventricle will be very fixed. So this interval will be always fixed. It will be happening at a particular rate. But when the same patient is having dual chamber pacemaker, it will be totally different. So we can say this is automatic time and this is escape time. I will not go into detail because these are totally different things. So VDD mode, VVI mode, you are seeing VVI mode, actual pacing, dual chamber. You have put the two leads, upper and lower chamber. Pacemaker put in the beats, there is missing in order to maintain the AV synchrony. Okay, so this is the time frame in which we do it. So A pace, B pace, A pace, V sense means native rhythm is coming. A sense, V pace, A sense, V sense means so there are different means they are having a lot of permutation combination. Maybe atrium may be pacing, sometime ventricle may be pacing, sometime both will be pacing, sometime both will be sensing. That's why DDD pacemaker is the most difficult pacemaker when we have to go for the timing point of view because there are a lot of timings are there. What is the PR? What is the what you can see the time frame? These are the almost around 8 time frames are running when the pacemaker is working means the windows are working. So that's why, and indication, the sixth silence syndrome when the patient is having AV conduction disorder. So these are the indication. I think we should not go for this. Okay. So there is one condition. I think it is better to discuss whenever we are putting the single chamber pacemaker. So AV synchrony will be always compromised because atrium when it is contracting, ventricle it is when it is contracting, it is there is a part of the cardiac output will be regurgitation will be happening. TR, MR can develop. So dyssynchrony also develop over the time. So it has been seen that some patient will start developing the heart failure, pedal edema will start happening. So in that scenario, the patient should be given the choice to go for the device upgradation. Means if the we call as a pacemaker syndrome. So the amount of blood which has to be ejected forward, it is being ejected backward due to the dyssynchrony. So in complete heart block, if you are putting a single chamber pacemaker, the chances of developing the pacemaker syndrome will be high because AV synchrony is compromised. So pacemakers, the result of the loss of AV synchrony, the atrial contact against the closed ventricle and the canone pulse and all those things. And there was a symptom of fatigue, dizziness, syncope, and sometimes the pedal edema. All those things will be happening. So any patient who is having pacemaker, if it is a dual chamber pacemaker, it is happening, then think about that atrial lead is not working properly, and there is AV synchrony is not happening, and usually it is in the single chamber pacemaker. This is all. So DDD, whenever we are saying pacemaker, it can be converted to DDI mode also, DDT also, VDD also, AI also, and VVI also. So DDD is a mode, means the pacemaker we can change. The pacemaker is having two wire, which can be utilized in a single wire also, dual wire also, sensing also, pacing also. So this happen means the patient is having atrial fibrillation, it will convert to DDI mode because atrial rate is very high. We don't want to track to the ventricle. So patient who is having a DDD pacemaker, it will convert to DDI. That functional part automatically it will convert. The same thing depending upon the condition. I think it is upper rate behavior lower. So I will stop on this point because these are some advanced things. It will need a different class for that. Okay. You should have your breakfast and let us go for the class our work. Okay. Any questions? Any queries? Nothing. सब लोग सब समझ में आ गए हैं. Huh? Everybody know. I will ask the question. Simple question. If the patient is having atrial tachycardia, what will happen? Pacemaker will do what? A dual chamber pacemaker, and patient is having one is atrial fibrillation has happened. What will happen in that condition? How the pacemaker will read that? What it do when the patient is having atrial fibrillation? They are very common. No? Patient has been implanted pacemaker. He has come to the ICU, and you are seeing there is something wrong is going on. So what are the wrong thing you can see? Wrong means ECG wise. What are the things you can expect there? Pacing is going or not? How you are going to identify? So two, three things are needed when the patient is on the pacemaker and you are knowing that patient is having dual chamber pacemaker. See the ECG first. If the higher rates means are you are getting narrow versus broad QRS first of all. So if it is a broad QRS, the chances is that it may be a pacing versus bundle branch block. If you are getting a spike, with each QRS, it maybe we are dealing a case of fast ventricular rate. In a case of atrial fibrillation, that may be a possible. But after a rate means that rate will be fixed. Last time, if you have attended the class, the patient pacemaker with the fast ventricular rate, it will go up to 70, 80, and after that, it will convert to DDI mode. So the heart rate will be always fixed. You are not getting P wave, but you are getting a very fixed heart rate of around 70 and 80. Normally, the pacemaker we keep around 60. So pacing will be mostly six and P followed by QRS, P followed by QRS, a P spike, P, then PR interval, and QRS will be there. When you are not getting a proper P wave, when you are getting a fixed QRS and the rate is around 870 or 80, it means the patient is having ongoing atrial fibrillation and device has switched over to DDI mode. It is sensing atrium, but it is not pacing according to that because heart rate is around 250, 350. It will not pace in that one. So you will say, okay, well, I am sensing 250, 350. I will keep the lower rate around 70 to 80 now. So this is called DDI mode switch has happened. And second thing is, if the patient own rate is QRS is narrow. So QRS narrow means patient native rhythm is going, and you can see 150, 160, 200, the heart rate will come. So the you can understand the patient is having ongoing having his own rhythm, and the disease is intermittent AV block. That is the one possibility. So in this situation, the one-to-one conduction is happening. Sometimes complete heart block is happening, or it may be a six sinus syndrome. So QRS is narrow. Are you getting this point? So these are the two ways that we have to see whenever the patient is having a pace. You are not getting a pacing spike, or if you are getting a pacing spike and heart rate is low. One is with P and QRS, and with one without P and QRS. Okay. And any patient who is having heart rate around 70, 80 plus, don't expect the spikes to be there. Spikes will not be there in that condition because in that scenario, that patient own rhythm is there and it is in DDI mode, means the heart rate. What we are doing when we are putting two wires, we are given, you should be in the silent mode when the patient heart rate is more than 60. So atrial rate 60, silent. It will not pace. Ventricle rate 60, it will not pace. So native rhythm is going on. And you are thinking that pacemaker is not working. So this pacemaker will work when atrial rate has gone below 60. It will give the spike of atrial. It will conduct over the wires, means AV conduction system. Again, it will wait for the time what we have timed it. So usually it will be 150 to 180 millisecond between the atrial spike. It will, when 180 millisecond has been expired and there is no sensing on the ventricle, it will give the spike. Okay, if anything within 140, 150, it has sense, ventricle has sense, okay, some QRS is there, means usually the ventricle is having two what you call anode and cathode. So any current will flow when the depolarization is happening. It will say, oh, sensing is happening, so it will become silent. So like that, sensing is being seen by the device. So pacing rate has gone, we have put the patient in the pacing mode, okay, 60 heart rate. So it means the device is reading whenever the atrial rate is going less than 60 atrial spike. Then after that the second period will come. It has been given you should wait for almost 180 millisecond. 200 is the usual first degree AV block process. 180 millisecond, if you have set it, wait for 180 millisecond. If you are not getting any ventricular sensing, then give a spike and QRS. Okay, and before it is coming, it will be there. So likewise, so if a lot of time people ask, sir, iska pacing spike nahi aa raha, to uska reason yahi hota hai. It will, and this is not expected in one condition जहां पर हम लोगों को स्पाइक मस्ट होता है, and that is called CRTD, CRTP, CRTD, where every beat we want to be controlled by the device. Except for the atrial, ventricle rate has to be controlled by the ventricle because we are resynchronizing the heart. So atrium, as a atrium, ventricle, and that is right and left ventricle, both has to be synchronized. So in that scenario, we want that the atrial, whenever sensing is there, tracking has happened. Now it must be having the QRSS, which is preceded by a spike. It may be small or big, that is a different, but it will be spike because we want to synchronize. First, uh, left heart has to contact, then right has to have, or both should simultaneously, either of these things. So this permutation combination, there is only one pacemaker where the spike is must, pacing is must, that is CRT. Dual chamber, single chamber, it may be possible depending upon the disease. But when we are going for CRT, which is for the heart failure, we have put the device for only one condition, to pace the heart and synchronize the thing. If it is not happening, we have lost the battle. But battle means the purpose of the pacemaker is not working. So if the patient is having a lot of VPCs, patient is having atrial fibrillation, this we will see the percentage of ventricular pacing. It will be saying V pacing is 70%, 80%. Then we'll say, okay, there is some issue with the device, means sensing issues happening, or it may be VPCs are coming, or atrial fibrillation is coming. Then we have to change the medication. Sometimes we have to change the pacing parameters to get the particular value, or it may be one of the lead is not functioning properly. So one condition where the pacing is must, that is CRT. ICD, not. ICD is a silent device. It is like a jet security. When the firing is happening, immediately go and capture the rhythm in your control. So that is ICD. So you should not expect that ICD, whatever DDD, VII, whatever is, it is kept heart rate around 35, 40. So here we want the device should pace when the heart rate has gone less than 40, then it should pace. It is not for the pacing function. There the device is meant only for giving the therapy when the lethal rhythm like VT and VF is coming. So identify and extinguish it. So for that, it will detect, okay, heart rate has gone 180, it is fulfilling the criteria of ventricular tachycardia by, there is a morphology map. So if it is normal sinus, it is like this one, morphology map is not matching it. Immediately say it is a VT, means like a cod blue. Immediately 8-bit shock if it is like that. So we set the device like that. Okay, up to 180, 220, match, give ATPs, means there is an anti-tachycardia pacing. So that is a very high current beatings we'll be giving. We'll raise, this is a normal VT at 180. We'll keep the this one at 220 so that it will chase and after that stop it. So we re-entry circuits are there, with tachycardia will terminate. Sometime it may not terminate, then it will shock it. So we call as a ATP, three ATPs we have given. Three times it will give the ATP and after that it will give a shock. Shock is the last option and that is not a preferred option most of the time. ATP has to happen and then the patient should go for the shock mode. Shock mode, it will automatically upgrade to shocking. So pacemaker, it should be intermittent versus continuous pacing. ICD, it is more sensing device with therapy during the VTVF. And when the heart rate is going very low, then it is a pacing mode. It has both the pacing function. ATP means for the terminating tachycardia and defib. All three are there. Means it is pacemaker with defib. That is called AICD. CRT, cardiac signal, it is having three leads to resynchronize the electrical activity, atrial, ventricle, left and right ventricle synchrony. If it is a CRTP, only these three functions are there. Means the three is lead and resynchronize. If we are saying CRTD, means it is having all the pacing functions, all pacing function plus ICD function. So it is a most advanced in the pacemaker point of view, or you can say device point of view. Thank you. Let us have breakfast.